Regarding calcific tendinitis, patient comes with a pain. This can mimic septic arthritis. X-ray would be shown with subcalcification at the level of the rotator cuff. On clinical assessment, there will be wasting of deltoid, supraspinatus, and infraspinatus muscle. Feel for tenderness in the fossa and insertion sites. Check for the muscle strength. Supraspinatus might be weak, unable to initiate shoulder abduction. Uh, check passively and check the difference between active and passive abduction. Ask the patient to push against the wall for winking or dyskinesis. Regarding the special test, power and lag test for each muscle should be done. Supraspinatus by Job test or drop arm test. Infraspinatus by external rotation and lag sign. Teres minor with external rotation in abduction and hornblower test. Subscapularis with belly press and lift off test. Examine the deltoid power as well at 9-degree flexion. The pathophysiology is calcification and tendon degeneration near the rotator cuff insertion. Build up calcium deposits. 3 phases: formation, resting, and resorption phase. Most painful is resorption phase because of the phagocytosis of the calcium deposits, and that causes pain. Ultrasound is sensitive for diagnosis. Plain X-ray can show calcium deposits. Treatment is number 1, physical therapy. Number 2, subacromial injection and then physical therapy. Ultrasound guided lavage, needling of the deposits called barbotage. There is some people will go for extracorporeal shockwave therapy. Other way will be arthroscopic open debridement of deposits. This is done in those patients which have snowstorm appearance and risk of shoulder stiffness.